Hi, I'm Dr. Maxine Jochelson. I'm a diagnostic radiologist and in particular, a breast imager. I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center. I'm a professor of radiology here and at Cornell Weill. So we have known for a long time that breast MRI is the most sensitive way to screen the breast for breast cancer. And it is advantageous because it's not limited by breast density. It does not involve ionizing radiation. It works by enhancing neovascularity. And this allows us to sometimes find a cancer before an actual mass can be seen. The sensitivity is close to 97%, and the specificity has gotten much better over the years at 63%. And the cancers we find with it are preferentially higher grade lesions, and the interval cancer rate is reduced if you're doing screening with MRI. So that's the good news. But there are reasons that MRI is imperfect. It is, particularly in the United States, very expensive, costs thousands of dollars at many institutions. It takes a long time, and the patients don't necessarily enjoy the experience of being in an MRI scanner. And some people still think we have too many false positive exams. But we know it's a great test. So several years ago, Christiana Kuhl came up with a brilliant idea that perhaps we don't need to do as many sequences when we do our MRIs. And perhaps we could use fewer sequences, get the same accuracy, but use less magnet time, less technologist time, less doctor time, and enable us to do more patients per hour at a lower cost. And so they set about looking into this and have published many papers since then, but one of the first was a study in which they prospectively read 606 screening MRIs in 443 women who were at some increased risk for developing breast cancer. They found 18 cancers in this population. The protocol to do the MRI in their hands took 3 minutes compared to 17 minutes for their full MRI. And other places take longer. We take a longer time to do our full than they do. But what they showed us is you don't need to do that many sequences. And basically, we can do them in about 10 minutes. The full abbreviated protocol took 28 seconds to read with a sensitivity of 100%. And the MIP image, the one that I'm showing you here, the single image, takes 2.8 seconds to read with a sensitivity of 91%. So clearly you don't need those many sequences that we use. Many others have studied this. This is a study that we performed here where we looked at a group of women who had a full breast MRI. We pulled out 3 sequences and read these blindly. And we, in fact, were able to find 95% of the breast cancers on the first run. And that was without having prior exams. And as you can see, look how easily you can see this cancer on all 3 of the sequences. Others have even looked at using abbreviated MRI in mutation carriers. Zelst et al. Looked at nearly 2,000 women, 2,000 exams in 900 women. And these were exams acquired in 2 minutes, and then they compared it to a full MRI, and they demonstrated that the sensitivity was equal, and the specificity was better because fewer sequences showed fewer false positives. So even in really women with very high risk, this exam seems to be equivalent to a full MRI. With this good baseline information, my colleague Chris Comstock and the ECOG Akron group did this, I think, practice-changing comparison of abbreviated breast MRI to tomosynthesis for breast cancer detection in women who have dense breasts, but not an increased risk. So they had over 1,500 women. They demonstrated both at academic and private institutions that you could do the scan successfully in 10 minutes or less. And abbreviated MRI found 143% more invasive cancers than tomosynthesis. And this is not surprising. There was a huge dense trial in the Netherlands where they did full MRI and also demonstrated that you find significantly more cancers in women with dense breasts, even if they don't have high risk. And this abbreviated MRI study really showed that it's so much better than tomosynthesis, and it doesn't take any longer for the patient to have the exam. So this is a great tool. The thing we have to do now, there's no CPT code for it, so there's no billing code. Women have the option at certain places to pay cash, and the price is about, let's say about $500 to have this. That's compared to thousands for an MRI, and it seems to be as good as a regular MRI. So we have to still get CPT codes. There's all the political stuff and the billing stuff, but this is a technology that may enable us to afford a lot more women to have screening MRI than we have been able to do before.